Today, we're diving into a topic that is just absolutely critical in healthcare: opioid pharmacology. Look, these are powerful, life-changing medications, and for nurses, understanding them inside and out, it isn't just some academic exercise, it is the very bedrock of patient safety. So we've got a really clear path laid out. We're going to start with the fundamentals, then we'll literally follow an opioid's journey through the body. After that, we'll decode some of those key pharmacology terms. Then we'll switch gears and focus on the nurse's specific role, and finally, wrap it all up with the safety principles that you just can't ignore. It's a logical flow that builds from the drug itself to you, the professional who administers it. So let's get right into the basics.
First up, let's just make sure we have a solid foundation. Before we can even begin to talk about safety or side effects, we need to be crystal clear on what we even mean when we say the word opioids.
At their core, opioids are basically a family of drugs that work by hitting very specific targets, opioid receptors, in our nervous system. And that interaction, it produces three signature effects: analgesia, which is that powerful pain relief; euphoria, which is that feeling of intense well-being; and the really dangerous one, respiratory depression. That's the risk we're always watching for.
I mean, you've definitely heard of these. This list has everything, from morphine and fentanyl that are used in super-controlled hospital settings to things like oxycodone and hydrocodone, which are commonly prescribed for pain. And yeah, all the way to heroin, an illicit example. The big takeaway here is that it doesn't matter if it's given by a doctor or sold on the street, the fundamental chemistry is the same. They're all part of the same pharmacological family. Okay, so once an opioid is actually given to a patient, what happens next? Where does it go? Let's follow the drug's journey through the body. This whole process, by the way, has a name: pharmacokinetics. And that journey pretty much always has four distinct phases. First, you've got absorption, which is just getting the drug into the bloodstream. Then, distribution, which acts kind of like a delivery service, carrying it to all the body tissues. Next up, the liver gets to work in metabolism, breaking the drug down. And finally, excretion. That's the cleanup crew, getting the drug and all its byproducts out of your system. Now, this brings us to a really important idea called the first pass effect. I love this analogy. Think of the liver as a toll booth. When you take a drug by mouth, it goes straight there, and the liver basically takes a toll. It metabolizes a chunk of the drug before it can even get out to the rest of the body. This is exactly why an oral dose of, say, morphine is so much higher than an IV dose of the same drug. And that leads us to a term every single nurse lives by: a drug's half-life. It's just the time it takes for half of the drug to be eliminated from the body. Simple, right? But this isn't just a textbook definition. It's the entire logic behind your medication orders. It's the reason a PRN pain med is ordered every 4 to 6 hours. It's all about keeping that pain managed safely without ever tipping over into toxicity.
All right, now we're going to decode some of the essential language. Think of this section as your personal translator for pharmacology. These are the words that help you understand exactly how drugs work and how they're described.
Okay, first up, agonist versus antagonist. An agonist, like morphine, is like a key that fits perfectly into a lock and turns it. It activates the receptor and causes an effect, like pain relief. An antagonist, like naloxone, is like a key that fits in the lock, but then breaks off, jamming it. It binds to the receptor, but it blocks it, preventing anything from happening. This is literally how naloxone reverses an opioid overdose. It goes in and kicks the agonist off the receptor. So people mix these two up all the time. Potency is all about the amount of drug you need to get a response. A highly potent drug works at a really small dose. Efficacy, on the other hand, is about the maximum possible effect the drug can produce no matter how much you give. A drug can be super potent, working in teeny tiny doses, but still have lower efficacy than a less potent drug. They are two totally different ways of measuring a drug's power. And here's a perfect everyday example to lock this in. To get rid of a headache, you might take 200 milligrams of ibuprofen, but you'd need, 650 milligrams of aspirin? That smaller dose means ibuprofen is more potent. But here's the thing. Since both can get rid of your headache, their efficacy for that job is basically the same. See the difference?
Lastly, let's nail down the difference between side effects and adverse effects. A side effect is something we kind of expect. It's often manageable, like a little drowsiness from an opioid. But an adverse effect? That's a severe, harmful reaction. We're talking organ damage that might mean we have to stop the drug immediately. It's a whole different level of seriousness. So, now that we have a good handle on the drug itself, let's pivot and talk about the person giving it,
The nurse's role is absolutely critical, and it relies on using systematic frameworks to make sure our patients are safe every single time.
The absolute foundation of all nursing care is the nursing process. It's a continuous loop, right? You assess the patient, you analyze what you found, you plan what to do, you implement that plan, and then you evaluate if it actually worked, which, of course, leads you right back to assessing all over again. It's not a one-and-done checklist, it's the constant, living cycle of care.
And building on that is the clinical judgment model. This is really about the thinking process. Our nurse recognizes cues, things like a patient's pain level or their respiratory rate, analyzes what those cues mean, prioritizes what the most likely problem is, generates solutions, takes action, and then evaluates the outcome. It's the how behind every safe decision we make.
Okay, let's bring it all home with our final and honestly most important section. With high-risk medications like opioids, safety is everything. There are layers and layers of protection and special things to consider that you just can never, ever overlook. So when you see a black box warning on a drug's label, you need to pay close attention. This is the FDA's most serious alert. It's a huge red flag. It means the medication carries a significant risk of severe injury or even death, and it demands heightened awareness from every single person who handles it. And remember, a dose that's safe for one person could be incredibly dangerous for another. Safety considerations change dramatically across a person's life. For pregnant women, there's a risk to the fetus. For infants, their immature system makes them way more sensitive. And for the elderly, declining organ function plus a whole bunch of other medications just creates this perfect storm for dangerous interactions.
And this is the mantra. The 5 rights are the non-negotiable final safety check before anything happens. Right patient, right drug, right dose, right route, right time. Following this simple checklist every single time prevents countless errors, and it absolutely saves lives. So we've looked at the drug, we've followed its journey, and we've gone over the safety rules. But it really all comes back to this one question, doesn't it? In a world filled with complex pharmacology, is it possible that the most powerful tool we have isn't a drug at all, but a nurse's judgment? For all the science behind these powerful medications, the ultimate safeguard isn't in the vial or the pill. It's the critical thinking, the careful assessment, and the clinical judgment of a well-informed nurse. And really, that's the bottom line.